Hey everybody, I'm Dr. Don Elton. I'm a pulmonary and critical care physician practicing in Central Florida. And today's video is about identifying and screening patients for pulmonary arterial hypertension. As you may well know, pulmonary arterial hypertension is distinguished from the more generic term pulmonary hypertension in that it refers to the disease where there is increased pulmonary vascular resistance leading to increased pulmonary artery pressure and reduced cardiac output. Pulmonary hypertension, the general term, includes PAH, but also includes elevated pulmonary pressures that result from left heart problems, which can include aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, left ventricular systolic failure, or left ventricular diastolic failure. So there are many causes of increased pulmonary artery pressures that are not related to the disease pulmonary arterial hypertension, which is a relatively rare disease. But we have treatment for the pulmonary arterial hypertension and often have treatment options for the people that have pulmonary hypertension not caused by increased pulmonary vascular resistance. So how do we identify people that need to be screened for pulmonary hypertension? Obviously, if an echocardiogram indicates increased pulmonary pressures, that's a clue that further evaluation is needed. But an echocardiogram by itself cannot rule in or rule out pulmonary arterial hypertension, or PAH. It can have clues on the echocardiogram, if you know what to look for, that can lead you in one direction or another, but it is not considered sufficient to start someone on treatment for pulmonary arterial hypertension, which again is a rare disease with multiple treatment options in terms of medications, but all these are very expensive and all have side effects. So you really want to have a proven diagnosis before you begin any kind of therapy for PAH. The echocardiogram makes an estimate of pulmonary artery pressure by measuring the velocity of blood flow backwards through the tricuspid valve, or the tricuspid regurgitant jet, using the Doppler technology of the echocardiogram. This depends on there being tricuspid regurgitation. If for whatever reason there is no leak, pulmonary hypertension cannot be measured with any degree of accuracy. And you also need to have a proper angle in the geometry of the echocardiogram probe. If you cannot get 90 degrees from the tricuspid valve, then you will tend to underestimate the jet. And if you have multiple measurements, which you almost certainly do, the proper technique is to measure the worst case as the pulmonary artery pressure. This is typically added to an estimate of right atrial pressure, which many times is based on whether there is collapse or dilatation of the inferior vena cava, to try to determine whether 5 or 10 millimeters of mercury should be added to that right ventricular systolic pressure estimate from the echocardiogram. The echocardiogram also cannot really tell you accurately the cardiac output, at least in most hands. There are some formulas that can be applied to try to estimate this, but these are seldom reported on standard echocardiogram reports. So generally that cannot be relied on. That's where the right heart catheterization comes into place. So what is a right heart catheterization? A right heart catheterization is when we place a catheter into a vein, thread it into the either superior or inferior vena cava, depending on the venous access approach, through the right atrium, where we take a blood sample for saturation measurement. We then advance into the right ventricle, take readings of pressure waves, through the pulmonic valve into the pulmonary artery, taking another blood sample, making measurements of the pressures, and then into a wedged position to try to get an estimate of left atrial pressure. In our use, we use thick cardiac output measurement, which is based on a calculated oxygen consumption. Again, these patients are all at rest in the cath lab, and the formula plugs in things like body surface area, age, and so forth. Again, a nomogram in the computer calculates out the volume of oxygen consumed per minute that is estimated. We actually measure the upstream and downstream oxygen content numbers based on the arterial saturation as measured by pulse oximetry typically, and the venous saturation taken from the pulmonary artery sample mentioned above. The other reason for taking two saturation samples is if you have a step up between the right atrium and pulmonary artery saturation of more than about 5 or 6%, this usually indicates that there is a shunt from the left side of the heart into the right side of the heart, increasing those saturations. The most common causes of this would be an atrial septal defect, though occasionally a ventricular septal defect can escape into adulthood and not be detected on exam or other echocardiograms not done with contrast. If this is found where there's more than a 5% step up, we generally recommend that a transesophageal echocardiogram with contrast be done to determine if indeed there is a shunt and trying to measure the size of the shunt and whether this is something that is amenable to repair or that needs repair. We're very careful in the cath lab to make sure that the zero, both electronically and with the level of the transducer, is correctly placed so that we get valid numbers. Too many people do a right heart catheterization and don't really pay attention to the accuracy of the number, but small errors in these relatively low pressure structures can make big differences in the diagnosis. And the difference between calling somebody left heart failure versus pulmonary arterial hypertension oftentimes is just a few centimeters difference in the level of the transducer. Ideally, the transducer should be placed at a level that is about 1/3 of the distance below the sternum to estimate the level of the left atrium in the patient's chest. And of course, with patients that are morbidly obese, sometimes this is a judgment call, but we always zero the catheter and make sure that we have a zero waveform before inserting the catheter, because once the catheter is inside the patient, you really can no longer adjust the transducer level in a meaningful way. Why not use thermodilution cardiac outputs? You certainly can do that. You typically take 3 measurements and take an average of the readings. Unfortunately, in my experience, patients with significantly abnormal, meaning low cardiac outputs and cardiac indexes, there seems to be more scatter in the readings. Further, if people that have arrhythmias or atrial fibrillation, sometimes the thermodilution can be fooled by this as well. I like using the Fick method, measuring the venous saturations, because we have to measure them anyway to determine if there is a shunt. But if the venous saturation is low, you know for a fact that the patient's cardiac output is low and not meeting the metabolic demands of the patient, which again, this is a patient at rest, lying on their back, pretty much motionless in the cath lab. And if the venous saturation is good, you know the cardiac output is adequate. It's hard to fake those low venous sats. You can fake a high one, but you can't really fake a low one in the cath lab. And this is a good double check to the accuracy of your cardiac output measurements. What sort of anesthesia is done? These are typically done under local anesthesia. I think in the last 10 years, I've given conscious sedation maybe one time for a cardiac catheterization, and that was a relatively young patient with Down syndrome with whom you really couldn't reason to keep her still to do the procedure. But everybody else was done under local, and nobody really regretted having local after the fact, but many people are anxious coming into the procedure. Most of the time, as far as site selection, we change an IV from the antecubital site that's placed by an RN using 2 guide wires to a micropuncture introducer and then to a 6 French introducer. And then we use a 5 French dual lumen pulmonary artery catheter through that antecubital vein and thread this centrally. This works out well for the patients. It shortens the procedure time. The access is essentially already there for you at the start of the procedure, and the recovery time is less, and it's less difficult to keep the site clean after the procedure to avoid infection risk. Approximately 10 to 15% of the time, the arm doesn't work out, either because the vein wasn't really adequately accessed or took a wrong turn and allowed the vein to be perforated during passage of the pulmonary artery catheter, or occasionally there is too sharp a turn up in the shoulder area and the catheter cannot be advanced centrally. Sometimes we can still make it work by passing a guide wire ahead of the pulmonary artery catheter, but this is not a 100% proposition. So we always prep the groin and use the right femoral vein if we're unable to get access through the antecubital site. But again, the antecubital site works between 80 and 90% of the time and is very popular among the patients. I've been asked many times at what pulmonary pressure on an echo should I be concerned about pulmonary arterial hypertension? And I usually give it back to you at what blood pressure in your arm tells you that you have congestive heart failure. It's important to understand that the disease pulmonary arterial hypertension is not so much a pressure disease. It's not the blood pressure that gives you the problem. The problem is the limitation in cardiac output. And all of the morbidity, mortality, and symptoms from pulmonary hypertension are a result of inadequate cardiac output to perform the activity that you want to perform, whether that's walking or running or exercising or just being alive. If the cardiac output is not adequate, you're going to have problems and shortness of breath. In people with pulmonary hypertension, the cardiac output is the main vulture vector that tells you how they're going to do and what their prognosis is. We generally look at three things to make somebody high risk for pulmonary arterial hypertension. One would be to have a mean pulmonary artery pressure over 40 millimeters of mercury, a right atrial pressure greater than 8 millimeters of mercury, or a cardiac index less than 2 liters per minute per meter square of body surface area. Any of these three things increase somebody that has increased risk of death from pulmonary hypertension. So again, cardiac output is key in this. We also calculate pulmonary vascular resistance. We use Wood units. To measure any resistance anywhere in the body or an electrical circuit or elsewhere, you take the upstream pressure, subtract the downstream pressure, and divide by the flow. So in the case of a right heart catheterization, this is taking the mean pulmonary artery pressure, subtracting the pulmonary capillary wedge pressure, or if a left heart cath was done on the same day, you could subtract the left ventricular end diastolic pressure, which is generally more reproducible than the wedge pressure when it's available, and you divide this by the cardiac output, and that answer gives you Wood units. A normal value would be 1. We typically treat pulmonary hypertension if the pulmonary vascular resistance is greater than 2 Wood units. The highest I've ever seen is somewhere in the 15 to 20 range, but those people don't tend to live very long at that range. But that gives you a general feel for it. The criteria was recently changed from a PVR of 3 down to a PVR of 2, and that's what most people are trying to use now to better identify patients early for pulmonary arterial hypertension treatment. And what about the wedge pressure? Normal wedge pressure is about 5. This is the amount of pressure it takes to fill the left atrium passively. If that pressure is greater than about 15, you consider this to be mostly a left heart problem, whether it's systolic failure, diastolic failure, or valvular heart disease. If that left atrial pressure exceeds about 20, most patients will have pulmonary edema and hypoxemia as a result of that. We don't tend to treat pulmonary arterial hypertension in patients that have wedge pressures over 15 because they don't meet the criteria, and using a pulmonary vasodilator to unload the pulmonary vasculature can occasionally result in pulmonary edema if the wedge pressure is already high and pushing into that pulmonary edema range. An exception to this rule might be someone who has extremely high pulmonary artery pressure, where the pulmonary artery pressure is so high that it is pushing the left ventricular septum into the left ventricle, creating diastolic dysfunction resulting from the high pulmonary pressure. In these cases, if you manage to get pulmonary pressure down or the flow better, you may unload that ventricular septum and cause less diastolic dysfunction. The wedge pressure could even possibly go down. But these cases are pretty unusual, and usually this will be mentioned in the report if we feel like this is part of the problem. What about secondary findings on echocardiography? I always make a point not only of looking at the right ventricular systolic pressure, but you want to see are there secondary findings such as right atrial enlargement without left atrial enlargement. If the left atrium is enlarged, you know there's at least some left heart disease probably contributing to that increased pulmonary artery pressure. Maybe it's the whole story, maybe it's part of the story, but you should always look a little suspiciously at patients that have left atrial enlargement and pulmonary hypertension on the echo. If you have right ventricular and right atrial enlargement, that goes towards pulmonary hypertension. If you have flattening of the interventricular septum, creating the so-called D sign, that's certainly important. Or if you have dilatation of the inferior vena cava. Also, if you look at a CT angiogram, if you see IV contrast in the inferior vena cava or into the liver, that indicates right heart failure. But you have to remember the most common cause of right heart failure is not pulmonary arterial hypertension, it's left heart failure. So again, you still have to consider that possibility. If you look at all the people that have increased pulmonary artery pressure, probably you have 4 people with left heart failure for every 1 with pulmonary arterial hypertension. So that's worth keeping in mind as well. So how do you decide who to refer? I already mentioned that this is not a pressure disease. Normal pressure in the pulmonary artery, the mean should be less than 20 millimeters of mercury with a systolic between 20 and 25 millimeters of mercury. The key, though, is exercise limitation and dyspnea that is not otherwise explained. So if you have a patient, for example, with severe COPD whose FEV1 is less than 40% of predicted and their walk test distance is perhaps 60% of the normal, that's a pretty good walk test for such severe lung disease. You don't really need to look for a cardiovascular explanation for that dyspnea. If somebody's had a lung removed and they have dyspnea, that's not unexplained dyspnea. On the other hand, if you have somebody with normal or mildly abnormal pulmonary function tests that is complaining of dyspnea, particularly if it is accompanied by a reduction in exercise performance, typically measured by 6-minute walk distance testing using standard instructions for the test, which is a big deal, then those patients need to be evaluated for cardiovascular explanations for pulmonary for their dyspnea. And this could include things like pulmonary emboli, heart failure, valvular heart disease, or pulmonary arterial hypertension, or occasionally emphysema that may not be apparent on their PFTs or on their x-rays. You won't always see that, or sometimes early interstitial lung disease that may not be picked up on a plain film. But you need to look for explanations in people that have dyspnea out of proportion to the obvious known findings. And the next step is to look at their 6-minute walk distance performance. If it's normal, it's unlikely you're going to make that patient symptomatically better by treating any pulmonary hypertension you may find. But there is data from a couple of clinical trials showing that even a 3-month lead in treatment of mild pulmonary hypertension can lead to better outcomes, and a 3-month delay in treatment can cause irreversible loss of function. So that's a big deal. And you really, if you're not getting back at least some normal right heart caths, you're not doing enough right heart caths, because that means you're failing to identify people that you might have helped with treatment to avoid progression. You have to remember that pulmonary arterial hypertension is still generally considered to be a fatal disease with a life expectancy of about 5 years. And unfortunately, it's still not unusual to find patients that have already spent 3 or 4 of those 5 years carrying a diagnosis of asthma that they didn't have, or COPD that they didn't have, or some other condition that they were just old and that was why they couldn't walk farther. So it's incumbent upon us, particularly as lung specialists, to identify these patients, because this is a very treatable disease with now 17, 18 drug therapies available and combination therapies. And now with sotatercept, one of the newest classes of pulmonary hypertension therapies available, with impressive results and up to 50% reduction in pulmonary vascular resistance, even on patients that had triple background therapy. That's really an amazing outcome. But it's very incumbent on us to identify these people early and perform the right heart cath, which is easy enough to get, only takes about 20 minutes on average, local anesthetic, home within 30 minutes of the procedure in most cases. There's no contrast risk. There is very minimal stroke risk compared to a left heart catheterization. The bleeding risk is lower since we're dealing with veins. As far as blood thinners, I generally want blood thinners held for 2 full days prior to the procedure, and assuming there was no arterial stick inadvertently or other bleeding issues, they can usually resume their anticoagulation as soon as they get home from the procedure. In any case, I hope this helps you identify patients that might need to have a catheterization done. Also would like to mention people with collagen vascular disease, particularly scleroderma. Pulmonary hypertension or pulmonary arterial hypertension is the leading cause of death in scleroderma, along with interstitial lung disease. So you should have a very low threshold for working these people up for pulmonary hypertension, at a minimum with annual chest x-ray, chest CT scans, if necessary, to look for interstitial lung disease, echocardiography, to look for signs of pulmonary hypertension, and also 6-minute walk distance testing to early detect exercise limitation that might indicate a problem. Note that the same changes found in the hands of Raynaud's disease patients can also exist in the pulmonary vasculature, which is thought in some cases to be one of the mechanisms of pulmonary hypertension in these patients. In any case, I hope you found this helpful. If you have any questions, leave them in the comments below and I'll try to answer. Don't forget to subscribe to the channel, share the content if you think others might be interested, and I'll see you next time.